Hi, good evening once again. I am back with Postpartum Complications. This is still maternity nursing. You want to watch out for the previous videos that you have not watched. This is Postpartum Complications. So Postpartum Complications, your priority thinking or what you would think is priority is the patient has complications, and your priority should be like how to take good care of them in this complicated state. Now, the first complication I will talk about is cystitis. We know cystitis, this is UTI, inflammation of the urinary tract system after delivery. Is a problem in postpartum, and it can occur in the postpartum period, and the woman should be encouraged to consume a lot of fluid. I had mentioned this when we spoke about the renal system. So urine specimen. So if a woman is suspected of having urinary problems and complaining of discomfort and blah, 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 you have to take the urine sample before you start giving them antibiotics. Don't go and tell the doctor to order antibiotics and then you come and start pumping it on the patient without getting urine culture. It has to be you have to take a specimen for urine culture and sensitivity. And this has to be gotten through straight catheterization, because remember, at postpartum period, you will not be able to get that clean catch urine. Remember, postpartum, the lochia is still coming. So if you ask them to pee, they're going to pee and there is blood, there's a whole lot of debris in there. So you want to take notice of postpartum cystitis and how to manage it. Antibiotics will be given, but that is after a straight cut to obtain clean urine sample. The next complication is hematoma. This is usually localized collection of blood in the tissues, and it can occur inside the vagina, which will involve the vagina organs, the vaginal area organs, the vulva. We have vulvar hematoma as well, which is most common. Now, I remember I spoke about uterine involution, uterine inversion in the other one, and uterine inversion, where the uterus turns upside down. For women who have had several children, sometimes after delivery, because they have had maybe like 10, 15 children, they'll be walking normal in their life and they have the uterus pop out of their vagina. Usually we manually just return it back through the vagina. It's not surgical, depending on the situation. So predisposing conditions for hematoma will include operative delivery with forceps and injury to the blood vessel. So if a woman had a forceps delivery and there was injury to the blood vessel, you can have postpartum hematoma around your vagina. So it comes as a little bump and it's on your vaginal structures. When you assess, what will you see? You see abnormal severe pain, not relieved with treatment, or discomfort. There will be pain around the site. Pressure in the perineal area, sensitive bulging mass in the perineal area as well, with discolored skin, and there will be inability to void. The woman cannot pee. So decreased hemoglobin and hematocrit level. Remember, mostly women who have forceps delivery will have this injury to their vaginal area, which causes bleeding. Remember, hematoma has to do blood, accumulation of blood. So the woman will be restless, and the vital signs will also change. There can be signs of shock since bleeding is involved, and tachycardia and hypotension. So what you will do, your intervention will be to monitor this client for pain and perineal pressure, pressure to the perineal area, especially when they did the delivery with a forceps, if it was a forceps delivery. You want to also monitor their vital signs and take note. You know the sign of shock, there can be signs of shock. So you also want to monitor for that, vital signs. And then you place eyes on the hematoma site. You want to stop it. So you don't want them to continue bleeding and exposing out and bumping up in the cavity. So you put eyes, you give pain medication, you prepare them for urinary catheterization, because remember, they are not going to be able to pee, and then administer blood product as prescribed. If you want to monitor them for signs of infection. So the signs of shock will be increased temperature, heart rate, and elevated white blood cells. Signs of infection, not shock. Signs of shock will be decreased blood pressure and increased heart rate. But for signs of infection, there will be pulse rate and white blood cell count will be high, elevated. You want to give antibiotics as necessary if there is an infection with the hematoma. You want to prepare them for incision and evacuation of the hematoma if it is necessary and required. Now let's talk about uterine atony. This is a poorly contracted uterus that does not adequately compress large open vessels at the placental site. So the placenta is attached to the uterus. So after delivery, the placenta detaches. So there's the need for the blood or that area to start bleeding. So if the large vessels around that site are not cooperating well, if they're not ready to clot, they're not responding well, the bleeding can be so severe. So the patient can have uterine atony. So this can involve the interior and posterior area of the uterus. That is where the placenta was attached. So assessment, there will be a soft, boggy uterus on palpation of the fundus. So the moment finished delivery, you touch the soft, boggy. And what you will do is to massage this until it becomes firm. This is the number one reason that can cause postpartum hemorrhage, remember. So you want to massage the uterus until it becomes firm. Because it's boggy, it's going to bleed. It's just soft. And it's a soft, smooth muscle, just allowing the blood to ooze. So you want to empty the mother's bladder. You don't want the woman to have full bladder because it's going to be pushing on the uterus and causing more bleeding. So you notify the OBGYN doctor to also put the patient on shock precaution or hemorrhage precaution. You want to start taking measures to help stop the bleeding. Now, hemorrhage and shock, postpartum hemorrhage and shock. This is bleeding more than 1,000 ml of blood after delivery, bleeding more than 1,000 cc of blood, which is, there will be 10% drop in the hemoglobin of the mother, and the hematocrit be dropped. So this can occur the first 24 hours after delivery, and later after the 24 hours following delivery, it can also occur. So we have the early postpartum hemorrhage, which is within the first 24 hours, and the late one, which is anytime beyond 4 hours after delivery. Anytime after delivery. So the late one will be the early postpartum hemorrhage is within the first 4 hours. Correct that. The early postpartum hemorrhage is within the first 4 hours. The late one is after the first 4 hours. And while postpartum hemorrhage can also occur anytime during that period, that postpartum period, usually 6 weeks, the greatest risk is within the first 4 hours after delivery. So immediately after the baby, and the second greatest risk is the first 24 hours after delivery. So you're worried what happened the first 4 hours after delivery, and from that 4 hours to the first 24 hours after delivery, you are worried about bleeding. Now, I'm going to talk about the causes of postpartum hemorrhage later, but for now, let's talk about assessment, what you will find. You see that the mother will be bleeding significantly. You can see the blood oozing out. And this one, the mother will soak a pad within 15 minutes. So you put the pad there, within 15 minutes, you go back and it's all soaked up, full. So restlessness, pulse rate will be the early sign. The heart rate will increase. That will be the early sign of bleeding. Decrease in the blood pressure, cool, clammy skin, and grayish color. There'll be complaint of weakness and lightheadedness. There can be shortness of breath as well. Now let's look at what you should do if a patient has postpartum hemorrhage and is in postpartum shock. Either postpartum hemorrhage and shock, because they go together. The mother will bleed until they go into shock. So you want to notify the OBGYN, you want to stay with the client and ask another nurse to contact the doctor. You don't leave the client to go and call the doctor. Let another nurse do that. If the uterus is atonic, massage firmly and to have it start contracting. So if the uterus is boggy, you want to be massaging it until it's firm. You want to elevate the legs at least 30 degrees angle, and you want to administer oxygen by non-rebreather face mask. Again, 8 to 10 liters per minute. I said that. Monitor the vital signs, and you empty the urinary bladder by catheterizing if prescribed. That's what you want to do. Then administer uterotonic medication. Example would be oxytocin, prostaglandins, to help slow down the contraction, or to help increase contractions, because oxytocin will increase contraction. Remember, the problem with this is because the uterus is not contracting well, so the mother will be oozing out blood. And you want to provide additional or maintain any IV fluid that is given. You want to give them lactated ringgers or normal saline. This is isotonic solutions. They are isotonic. You want to bring up the fluid volume. So you use at least 16 to 18 gauge needle, and you want to have 2 lines on the patient where you can give fluid plenty. And remember, blood transfusion too will be necessary. So you administer emergency medications as prescribed. You administer emergency prescribing, and you monitor the input and output, because you're giving the patient fluid. You don't want to overload their heart as well. Now let's talk about postpartum infection. Any infection of the reproductive organs that occurs the first 28 days of delivery or abortion. We have endometritis, which is inflammation of the inner lining of the uterus. It's a number 1 problem. When you assess such a woman, you see fever, chills, anorexia. You'll have abdominal pain and discomfort, vaginal discharges that will be that would not be like a normal discharge. So normal vaginal discharge will have fleshy odor or an odor that is similar to menstrual period. That will be normal vaginal discharges. So there will also be elevated white blood cell. So a temperature above 100 degrees Celsius is a sign of infection in the postpartum mother. The temperature above 104 is a sign of infection. The first 24 hours after delivery, the temperature is 100.4. Remember, this is expected. It is expected slightly, 100.4. But after the first 24 hours, 2-3 days, the patients still have a temperature of 100.6. Is a concern. Now, what will you do? What are your interventions? You monitor their vital signs and their temperature every 2 to 4 hours. So you make the client comfortable as much as possible, and then you also position the client to promote vaginal discharges, and you keep the client warm if they haven't chills. You want to isolate the newborn from the mother, because you don't know what's going on with the mother right now. It could be infectious, and especially now in the COVID days, every fever is questionable. So you want to provide high-calorie diet as much as the mother can tolerate. You want to increase their fluid. You encourage them to take fluid up to 3,000 to 4,000 liters a day. If the fluid is not contraindicated, they don't have other comorbidities or other problems that will cause them to be on fluid restriction. Then the last thing is to give antibiotics. Let's talk about mastitis, inflammation of the breast. So inflammation of the breast it affects milk production. It affects milk production and is a sign of infection. So it occurs in the breastfeeding mothers 2 to 3 weeks after delivery, but may occur at any time during lactation. Usually the first 2 to 3 weeks after delivery, but usually throughout the period of breastfeeding can be like 6 months after delivery. You can have mastitis, inflammation of the breast. When you assess, there'll be heat and warm, swelling, pain, tender. You know how it feels tender. It will be tender and warm to touch. The mother will have fever and they'll have flu-like symptoms. Now, your interventions is to instruct the client in good hand washing and breast hygiene, good hand washing and breast hygiene techniques. You also want to encourage them to promote comfort. You apply heat to the site as prescribed warm packs. If I would say, you maintain lactation in the breastfeeding mother. Let them continue to breastfeed. It's painful, it's not easy. You encourage manual expression of the breast, or you encourage them to use breast pump every 3 to 4 hours. You encourage clients to wear supportive braces, and then you administer analgesics as prescribed, and you also give antibiotic. Now let's talk about pulmonary embolism. I have talked about this before, but let's just go over and see what it is again in the postpartum period. So you massage. Pulmonary embolism is the passage of a thrombus, often originating in a uterine or pelvic vein, into the lungs, where it disrupts circulation of blood. It's a blockage, and it stops the circulation of blood. You will see that the mother will start having shortness of breath suddenly, complain of chest pain. There will be tachycardia and difficulty breathing. They will have coughing. You listen to their lungs, you hear crackles. They will be vomiting blood, and then the feeling of impending doom. This is an emergency, so you give them oxygen right away. Position them with the head elevated, head of the bed elevated, as a Trendelenburg, head of the bed elevated, not Trendelenburg, head of the bed elevated, like above 30 degrees or 30 degrees and up. So you want to monitor vital signs frequently, especially the respiratory and the heart rate. You want to monitor them for any distress and hypoxia. Remember, there's a blockage, oxygen exchange will be less. That's why they have signs of impending doom, because they have difficulty breathing all of a sudden. We have anticoagulant that you can give that has been prescribed, and then you also want to prepare to assist the provider in medications that will help dissolve the clot if recommended. Then let's look at subinvolution, incomplete involution or failure of the uterus to return to this normal size and condition. The uterus refuses to go back. So when you assess, you see uterine pain or on palpation, you palpate, you see that the mother will still have pain after 10 days. And uterus will be larger than expected. After 10 days, it's still large. You can still feel it. There's normal vaginal bleeding at that time. Remember, I have said that if you can still feel it after 10 days, that means it's the sign of infection. If it's tender and thin. So you want to assess the vital signs. That's what you should be doing. You assess the fundal height. You monitor uterine pain and vaginal bleeding. You elevate the mother's leg. You encourage them. You encourage the mother to void. So you want to encourage voiding. You want to administer metal ergonovin mallet, which will provide and sustain contractions for the uterus as prescribed. So ergonovin is a medication that you're going to give them to help with contractions, to have it come back to normal. Now, thrombophlebitis, a blood clot in a vessel wall as a result of inflammation of the vessel wall, blood clot in the vessel wall as a result of an inflammation. So there will be partial obstruction of vessels that can occur, and increased blood clotting factors in the postpartum period place the client at risk. You know, postpartum period, because of the uterine contraction, there is increased blood clotting factor, factor K. You know, the blood clotting mechanisms are initiated because it has to stop, the uterus have to stop bleeding. So it's a lot of them that will be activated, and if they are activated, there's increased risk for disease can cause thrombophlebitis. So we have different types of them. We have the superficial thrombophlebitis, femoral thrombophlebitis, and pelvic thrombophlebitis. I'll talk of the assessment in a little bit, but for now, let's look at the interventions. There are specific therapies which depends on the location of this phlebitis. And then you want to assess the extremities for Edema, tenderness, very warm, and then increased skin temperature. That's warmth. You want to maintain bed rest, and you want to elevate the legs up. You want to apply bed cradle and knee bed clothing off the affected leg. So you never massage the leg to have it declot. You want to monitor for manifestation of embolism. You also want to apply hot packs or moist heat to the affected site as prescribed to elevate the discomfort, and you give analgesics. Heparin will always be given for femoral and pelvic thrombophlebitis, and this one will prevent the thrombus formation. We know heparin is a blood thinner. So let's talk about prenatal loss. Prenatal loss associated with miscarriage and neonatal death, stillbirth, and therapeutic abortions. This is loss and grief which may also occur with the birth of a preterm baby, a newborn with complications, or a newborn with congenital anomalies. When the newborn dies, that's prenatal loss. So it is not all interventions that are appropriate for every woman and her family who has experienced prenatal loss. It is crucial to consider their religious beliefs and spiritual understanding and their healthcare practices and beliefs when you are planning care for women and their family who have experienced a prenatal loss. So you want to take their spiritual and their coping mechanisms into consideration. Therapeutic communication will be nice for them. Be an active listener. You want to provide parents time to grieve. Give them space. Don't tell them stop. Don't make noise. Give them time to grieve. It's a loss. I have mentioned this one, and I know by now we would have known what it is. So postpartum hemorrhage, the causes of postpartum hemorrhage, I had spoken about it, but I'm going to talk about the causes will be either uterine atony, laceration of the cervix or the vagina, if they had to cut it to have the mother deliver, if there is hematoma in the cervix, perineum, or the labia retain placenta fragment, if they are retained placenta product. Now let's look at predisposing factors. Predisposing factors is a woman who has previous hemorrhage, previous postpartum hemorrhage. We bled with a previous pregnancy, you are at risk. Placenta previa, placenta abruptio, improper implantation of the placenta, improper attachment. Remember placenta previa, it attaches itself, we have the partial one. If it doesn't attach well, it can bleed, it can cause postpartum hemorrhage. If it suddenly detaches, that's abruptio, it can cause postpartum hemorrhage. Over distension of the uterus, this I spoke about. Multiple gestation, large baby. The baby is very big and have pushed the abdomen to be distended. Infection, so many babies, multiparity, dystocia or labor that is prolonged. Prolonged labor, operative delivery, that's C-section or forceps delivery, and intrauterine manipulation. If they have to go and manipulate the uterus too much, the uterus cannot be bothered so much. Now let's look at assessment of the types of thrombophlebitis. I spoke about this, and we have the superficial thrombophlebitis, we have the femoral and the pelvic. Now the superficial one will be palpable thrombus that feels bumpy and hard. It will be palpable, it will feel bumpy and hard. There's tenderness, pain in the affected lower extremities. So there will be warmth and pinkish red color over the thrombus area as well. The femora will, if it's the femoral thrombophlebitis, the mother will have malaise, fever, chills, reduced peripheral pulses, shiny white skin over the affected area. There will be pain, stiffness, and swelling of the affected leg. How about the pelvis? Let's look at the pelvis thrombophlebitis, pelvic thrombophlebitis. There will be severe chills, dramatic body temperature changes, and then there will be pulmonary embolism, which may be the first sign. Client education for thrombophlebitis, I spoke about it. Never massage the legs. Avoid crossing legs. You don't let the client cross their legs like this. Avoid sitting up. Avoid prolonged sitting. You can sit, but you cannot sit too long. And then you want to avoid constrictive clothing. Constrictive clothing. You want to avoid behind the knees. You want to avoid behind the knees. You want to avoid like bending towards your knees or folding your legs and irritating that side. So you need to know how to apply elastic stockings. So you teach the client to put on elastic stockings or support hose if they are recommended for them. So you also want them to be compliant with anticoagulant therapy. This will help break out the clot in them. So you also want them to have the understanding of the importance of follow-up with their healthcare providers. You know, we have some patients that they just want to go home and that's it. They never want to come back. So all along, I have been talking about postpartum complications, problems that come after a woman finished delivery. I spoke about cystitis, UTI, hematoma. I spoke about uterine atony. I spoke about hemorrhage and shock. That's postpartum hemorrhage and shock. I also spoke about infection. I spoke about infection, like postpartum infection in the uterus mostly. I spoke about mastitis. I spoke about pulmonary embolism, which is an emergency. I spoke about subinvolution, thrombophlebitis, and then prenatal or perinatal loss. This is loss of the newborn. And then the postpartum hemorrhage and how to care for a woman in postpartum hemorrhage. So on this note, this brings me to the end of this video. This brings me to the end of this video. I have been discussing the content for maternity nursing. This is maternity nursing, and that is the content for it. The last video on this will be care of the newborn. Care of the newborn. And we are done with maternity nursing. You would have had all the information you need to know, all the content and the underlying information, the foundational information of maternity nursing, and the questions you will ask. You will be asked to answer on the NCLEX. All you now need is to put it into practice, use critical thinking, understand the baseline information on this, and you will be on your way to getting your RN license or your LPN license, which you need it. You have gone to school to get this, and it's now worth it to keep struggling, get to understand the content, and study and use critical thinking to answer those questions, because they're not going to ask you questions that are not out of the content or that are not what should be done for a patient. So those are not framed questions. They are real questions. So take notes and let me know if you have any questions. Get back to me and let me know if I can be of help in any way. But on this note, this brings me to the end of postpartum complications and one more video that is care of the newborn after the baby is born. What do? We care for them. And see you later. Goodbye.